Welcome. Delighted to have you with us today. It's Victoria Schneps, and I've got Wendy Goldstein, the CEO of Lutheran Medical Center, with me today as part of our interviews for Victoria's Stars. I'm the publisher of the Home Reporter and the Brooklyn Spectator and the Spectator News, and we're delighted to have you have something live besides our newspapers and our websites to enjoy about the leaders in our community. And no one is a greater leader, probably nationwide, than Wendy Goldstein, who runs Lutheran and has really achieved greatness for this hospital and therefore for the community that we serve.
Thank you. It's
Welcome.
Very gracious of you.
Well, the facts are the facts. So tell me a little bit about, how did you get to where you are?
Oh my goodness. Well, I spent most of my career really in academic medicine, which was at the big academic medical centers. I have an MBA.
Were you local? Were you in New York born and bred?
Born and bred.
Okay.
My undergraduate years were in Boston, but other than that, it's been New York all the way.
Okay.
And my MBA actually is from a combined program from Mount Sinai School of Administrative Medicine and Baruch through the.
So what put you on the path of wanting to be an administrator? Because that's, I don't know, years ago
very
it wasn't
unusual.
Right?
Very.
Yes.
I didn't realize how unusual.
Okay.
You have to understand. I think that first of all, I was, in many ways, my father's son, if you will.
Interesting.
So it was, I was definitely going to have a profession. And I was limited, like so many young people are, to even know what exists out there. I thought I wanted to be a lawyer for a while, then I got engaged to one, and I decided that wasn't such a good idea. And my father actually was an engineer who did some of the very early work on intensive care units in hospitals. And
now, was he an engineer?
He was an engineer. He was an engineer, and actually St. Francis Hospital out on Long Island, which is a very fine cardiac hospital.
My husband was a physician there for 35 years.
I had no idea. Well,
yes.
There you go. So anyway, he did some of the very early design work on the air handling in the cardiac care unit.
Interesting.
So, and I'm sort of bouncing around in my junior year of college, and he said to me, well, there's something called a hospital administrator. I'm not exactly sure what they do, but there seems to be a lot of opportunity for somebody smart.
There you go.
So there I go. And I went to the Baruch program, which was an excellent program, and I started out in Manhattan. My first major job was at New York University Medical Center. I had this wonderful opportunity to operationalize one of the first quality assurance programs. They just came into effect in 1975. And they were looking for a woman MBA to do it. You'll enjoy this. They didn't want a man because they thought it would be too intimidating for the doctors, and they didn't want a nurse because they thought they would be too smart for the doctors. So a woman MBA seemed like a safe thing, and there weren't a lot of us around.
Because I remember you telling me that your class had how many women?
3.
Right, so it was really a special
it was
positioning.
In fact, in the 60s, it was quite open. The Yale program and even the Columbia program in the 60s did not allow women unless you were a nurse or a nun.
Isn't that interesting?
Yeah. But healthcare really became a business in the late 60s with the passage of Medicare and Medicaid. Suddenly, the federal government in 66, 67 is a major payer. And the whole nature of the business changes, the industry changes. It was a charity before. It was something, you did to run a hospital as a nurse or a nun or a physician. And now suddenly there are business issues, and there's a crop of us that come out. I didn't know that it was sort of the last bastion of male chauvinism, and it was quite overt. But I was very, very fortunate being in New York and having some wonderful mentors. And I was, as I said, at NYU. Barbara Eisenberg, who has since passed away, was really my mentor, and she was a professional woman. She told me how to dress, she told me how to talk.
So it's okay to tell your staff how to dress. I like that. I'm glad you said that to me.
Absolutely.
Because sometimes I'm wondering how people dress for success and they don't know about it, and how you have to be in a different role dressing than if you were in another position.
Well, I was a kid. I was 22 years old, and suddenly I'm sitting in Board of Trustees meeting. because I was very fortunate because of the work that operationalizing the quality assurance. It was brand new, and so they brought me into the board meeting. And it was really a fabulous opportunity because I got to know...
That was a very big board in terms of who they were in the Society of New York.
Absolutely. Well, many of the boards at the academic medical centers. So we, Gerald Cole was there. I mean, there's always a building associated with these people. And then later on, my next move was to Memorial Sloan Kettering. And there I'm sitting next to Lawrence Rockefeller, thinking, your grandfather gave my grandfather nickels. So it was sort of an extraordinary experience.
Was he a real person? Was he,
He was so dedicated to that institution. A very different institution, very different perspective.
Was it new at that time, building its reputation for cancer care?
It wasn't new, but it was reinvigorated.
Okay.
They had just recruited the dean from Columbia, and they really wanted to make a significant impact. It was businessmen, and they wanted an ROI. They wanted a return on their investment. They wanted cancer cured. And they made enormous strides with the people. Dr. Paul Marks did a lot of the recruitment and brought them to a whole new level. I think everybody would agree with that. So I had the opportunity to be there, and then
Because I would think that was a learning experience, just being around people of that caliber.
Yeah, well, and
to see how they operated.
Of course, and it was just very different than people I was exposed to previously, and it was great. It turned out not to be the right place for me because I think you have to know what kind of institution you feel comfortable at.
Explain to me about that. What do you mean about that? What was it came to you that made you feel that way?
Well, I think that the most important thing, truthfully, was that it was so dominated by cancer. I can remember one of the doctors saying to me, "Why are you so upset? We're curing 60% of pediatric leukemia now," which was extraordinary. But I kept looking at the 40%.
Yes.
I had twins. They were 2.5 years old. And I would...
A boy and a girl?
2 girls.
Identical girls. Identical girls.
Very proud of them. But they were 2.5, and I would go to work every day, and I would see these children. They had 500 pediatric cancer visits a week. I couldn't handle it.
Yeah, I can understand that.
So I knew that just wasn't the right fit, and I was significantly younger. I was a vice president at 29.
Oh, my.
I was the only woman. It was not a good fit. So I had this opportunity to move to Mount Sinai, which I never thought I would work at. Having gone to school, you sort of have a little bit, the warts a little bit too well. But it was this wonderful opportunity because I had been doing staff work before, and that was open to women. So I did planning, I did quality, I didn't do direct operations.
Interesting.
And so I was going to go to Mount Sinai, go for 2 years, learn everything about operations, of course, and then go back to staff work. And I fell in love with operations. And it sort of fell in love with me.
So when you talk about operations, to explain to the layman, what does it involve? What are the departments that you have to worry about?
Responsible for the day-to-day operations that provide the product that you're doing. Our product is patient care.
Right.
So it's having nursing report to me. It's having radiology and laboratories and operating rooms and doctors report in to me.
So I see a conflict right away because I know the male chauvinism is there, and I haven't been married to a doctor. I know there tends to be that feeling. So that was something to overcome.
It was. In fact, I was recruited, not recruited actually, I got the job in 1982. And the then president, during my interview, I'll never forget, said to me, "I don't see how you can be a good mother and do this job." And I told him that he shouldn't judge me by the parochial tenets of his own marriage. And I was quite successful as a mother right then, coming, I felt, as a vice president from Memorial Sloan Kettering. But the head of the medical staff at that time, who subsequently became a dear friend and a wonderful supporter, actually went to the president of the hospital and said that he didn't think it was an appropriate job for a woman.
Wow.
Yep. But they gave me a chance, and I think, there are some situations where it doesn't matter how good a job you do. There's so much bias. But I think in this situation, they were suspect, but they were willing to be proved wrong.
Okay.
And I really...
That was a forward-looking decision.
Yeah. And I worked very hard, and I guess the turning point came, there was a large strike in 1984, 46 days. And basically I didn't leave the hospital for 46 days.
Oh, my.
And that sort of, the doctors had a very different attitude towards me after that.
That was the turning point.
It was. It really was. And then it was just better and better all the time.
So you have been at Lutheran now how many years?
12 and a half years. It's extraordinary because, I always said to myself, oh, well, I was at Sinai 16 years, but I'm upping there right now. So it's wonderful.
So you really are living through great changes.
Enormous changes.
That, happened in the 60s when there was the great change with the Medicare and Medicaid coming in.
Right.
To some extent, this is very similar in terms of the whole way we're looking at medicine from a government perspective and insurance. And I know you've got some grave concerns about a safety net that's being taken away from you. So why don't you tell me about that?
The huge difference between the 60s and now really is in the 60s there was really an embracing of the social contract. The idea that government was going to play a bigger role and help people, building on Social Security from the 30s and so on. That was a sort of a logical culmination. Now, it's not that way at all. I think that these changes, which are largely coverage changes, insurance changes, are questioning how much money that we want to spend in healthcare, how we want to spend the money. And so, in a lot of ways, we don't find it politically acceptable to be frank about some of the cuts that are coming along with this. And so we've sort of wrapped them up in what sounds like very good things to do, like readmissions. Hospitals are now penalized for readmissions, and that makes sense in a certain way because if the hospital has an incentive to keep the patient healthy, it should be better.
But do they give you because I know there's the 2 days in and then you better be out of here because there's no insurance. I mean, have they extended that?
No. In fact, the data really indicates that if you have a large Medicaid population, a poor population, you're going to have a higher readmission rate because the people don't have the social infrastructure to keep themselves out of the hospital. They have difficulty with language, and so they don't get their medications correct necessarily. So we're being penalized for something that sounds great, and also we're being penalized 30 days out. It's one thing to say to a hospital, and I think there's been data that shows if you get a patient discharged from a hospital and they see a provider within 7 days, it makes a difference. And certainly we've been incentivized to do that, but not 30 days, and not totally unrelated things. So if you're in my hospital and then within a month you got hit by a car, I'm penalized for that.
Incredible. Is anybody listening? Do you feel like you're talking to the air? I mean, I don't know if this is, a Congresswoman Nydia Velázquez is such a wonderful Congresswoman. If we have to beat down her door to get to her, because it seems like is this a federal
There's
positioning?
A lot of federal.
I mean, I don't know if the city or the state have much to do with this at this point.
Oh no, I think the state has an enormous amount to do with things. They really do. And New York has been very forward-thinking of all the states. And because of that, actually is benefiting less from Obamacare than states that have not been as forward-thinking.
Well, explain to our viewers about this issue of having lost millions of dollars because of the reorganization of the way funding comes to you.
Well, there's a couple of different things. First of all, there is a myth, there's sort of three myths of Obamacare, but one of the prime myths is that there's not going to be a need for disproportionate share dollars. Disproportionate share dollars are what people think of as charity care dollars, and hospitals get them to compensate for the fact that some people have no insurance and many people have underinsurance. Medicaid was well known when it was established, does not cover costs. It's not intended to cover costs. And the idea was that this bucket of money would compensate those hospitals that had so many Medicaid patients that they couldn't shift the cost to other payers to make up the difference. So that if it costs me $1 to provide you with care, Medicaid is going to pay me 80 cents, but the commercial insurance companies before paid me $1.20. Okay. So if I have enough $1.20s, they offset my 80s, and I'm okay. In an institution like Lutheran, and many institutions in Brooklyn, there are many, many more 80-cent patients than there are $1.20 patients. We cannot cost shift because there is not the patients to cost shift to. And so we relied on disproportionate share dollars. We got $50 million a year, Lutheran, in disproportionate share dollars, essential to our functioning. And now 75% of that is going to be taken away.
So how do you scream and yell that this can't be?
I've been yelling and yelling and yelling, and
now
yelling for 3 years.
Is this the state that can control this? Then the money comes from the feds to the state, and then the state disperses. What's the road map of this?
Well, I think really the large redistribution is a federal initiative, and then there are changes also at the state level. But really, this is a federal initiative because so everybody's supposed to get covered under Obamacare, so there won't be any of this need. Well, there's a couple of fallacies with that. One problem, of course, is the undocumented. And then there's a reality, and there's a reality in Brooklyn, and we have a
reality is
wonderful,
huge,
vibrant, exciting immigrant community, but there are many undocumented people, and we absolutely make no differentiation in the cost, in the care we provide. But they not only don't have insurance, they're not allowed to buy insurance under Obamacare. So there is still going to be 1 in 5 people that walk into my emergency.
So they cannot have any insurance. In other words, just that they, and before, what was going on before this all started?
Well, what was happening before is they didn't have insurance, but I had these disproportionate share dollars to compensate for it.
Okay.
Now you're going to take away my disproportionate share dollars, but I still have my obligation, both morally and legally, to provide care to people regardless of their ability to pay.
Remarkable.
And it's a huge problem for, I think, certainly Brooklyn providers. And then, so that's something that just isn't addressed at all. And immigration, as you know, is a very hot topic. And I think the hope was in 2011, when things were really getting going with the healthcare reform, that they would take care of healthcare reform and then they would take care of immigration and it would all work out. Well, you know what's going on in Washington better than I do.
Dysfunction.
So the immigration
it's scary.
It's terrifying.
Yeah.
It's terrifying. And the immigration issues have not been addressed, which has implications in so many areas.
Well, I don't think anyone quite got that the immigration issue really is affecting health care.
Right.
You know, there's kind of like a disconnect in terms of that.
Yes.
That people need to understand that, and sometimes our political leaders don't quite get how critical that is.
Right. Well, one of the things that's happened, and I think this is very unfortunate, is really we've just been made into villains. We've been vilified. Hospitals, doctors. You know, people are concerned about fraud, and you know, people get too much care, and there are empty hospital beds. You know, and the facts don't seem to convince people.
Isn't that remarkable?
It is. And is there anyone who commits fraud in the Medicare and Medicaid? Of course there is. There's fraud in everything. You know, the Attorney General keeps himself quite busy with fraud in Wall Street. But that doesn't mean everybody in Wall Street is corrupt. And hospitals are working very hard, particularly in New York, to provide services. And we provide lots of services because Medicaid has built those into the program so that New York provides coverage for mental health services, behavioral health.
Right.
Very important. Other Medicaid programs don't provide it at all.
You mean when you say other Medicaid, you mean out of the states? So
other
states that are not getting that service.
Right.
And so what happened to us?
So what happens to us is we look like look how much New York is spending on Medicaid. Well, yes, we spend a lot on Medicaid, but we spend a lot on Medicaid because we pay for long-term care. Other states don't pay for long-term care, and that's a huge problem with an aging population and nursing homes and so on. But if you take that out, that's the place, really, where most of the money is spent, is on the blind, the disabled, and on long-term care, which are social decisions the state has made. We've decided that we, as a state, want to take care of these
as a society.
Right. And I'm very proud of that. That's
right.
wonderful. There's a cost involved. And to sort of turn around and go, well, why is it costing more? Well, it's costing more because we cover dental services. Other states don't provide dental care. So when you look at all these pieces, the institutions and the doctors have been really made into bad guys. And the dialogue, just like this dialogue between the Republicans and the Democrats, regardless of which side you're on, there isn't a good dialogue. The providers have not been able to get the attention that they should because it seems very simple.
Well, in Brooklyn we have a big controversy with hospitals that are weaker, like Litch, and how they are going to be able to survive or should survive. Right. I know that in Brooklyn, Queens border, there's a hospital called Wyckoff, and they are $1 billion energizer to the economy.
Right.
And they're not just serving people, they're also providing jobs, and they're providing all the peripheral things that make a neighborhood strong.
Right.
So where do you see what's going to be in Brooklyn and your region?
Well, I think the thing is, first of all, this is not a one-size-fits-all situation. What's right in one institution isn't necessarily right in another one. And Wyckoff, I have to say, all of us are sort of standing back and seeing that a lot of good work has been done and a lot of turnaround. But that doesn't mean that every hospital in Brooklyn needs to stay open. Long Island College Hospital has been running a deficit for almost 19 years.
How did the board permit that? I mean, how has that happened?
I think that they've struggled. There's, it's very easy to second guess and look back and sort of say what happened and so on. But for a lot of different reasons.
But you don't run in a deficit, do you?
No, I'm very fortunate. I don't run in a deficit, but I ran in a deficit before I got here, and we owned Health Plus, which was an insurance company, and we used the surplus from that to offset it. And when I got here, I said, look, to the board, I said, give me 5 years. I'll use the money from Health Plus to invest in Lutheran, to build it, and then we'll break even from operations, which we've done for the last 8 years. So I'm very
And then
proud
you
of
sold Health Plus.
Yes, we did sell Health Plus. We sold Health Plus because we needed money.
Okay.
We had a very significant defined benefit pension program, and through some circumstance we have our own pension program, and we had obligations to it, and we made it was a very tough decision for the board because they believed in Health Plus. We set up Health Plus in 1984. I say we, I wasn't here, but I'll take credit for it.
Yes. Hugely successful.
So I might as well take the blame, right? But we were asked by New York State at that time to pilot this idea. They knew they had something called Medicaid and they had something called Blue Cross, but there was a gap. There were a group of children, and it was really focused on children initially, that didn't have coverage. And so in a very forward-thinking way, they tried to put together something called Child Health Plus. And they piloted that in Brooklyn at Lutheran and at Syracuse upstate.
Interesting.
And so when this became a law and it became a program, Lutheran had the wonderful opportunity of turning its pilot program into a company, which ultimately we spun off into a separate company, and it became an important asset. When St. Vincent's Medical Center, in fact, went bankrupt, we took over their homeless program. But we ran it as a federally qualified health center, which we have, which I'll tell you about in a second, but we went from a $2.5 million deficit to $1 million surplus in that program by cutting it down and by being reimbursed differently. And we did that in partnership with Mount Sinai, who upfronted the money for us for 1 year on the faculty, and then we did it. But St.
Interesting
Vincent's,
strategies.
well, St. Vincent's hadn't been an effective biller. But the other reason why Lutheran is in as good shape as it is, even though it is extremely fragile, is that the people that built the hospital where it is today, and we are now we're retrofit into a factory building that had been abandoned under the Lindsay administration.
And your neighborhood is getting sexy and gentrified.
A little slow on the gentrification, but...
Well, somebody just told me recently that they're calling parts of Sunset Park Park Slope South. I love it.
Well, I think we're very solidly in Sunset Park, so I don't know about that. But what was established then was instead of opening up hospital clinics, they opened up a community-based, a federally qualified community-based health center. And the significance of that is that for all these last 45 years, we have a federal reimbursement, which for that particular set of things is cost-based. So whereas for years, institutions lost millions and millions of dollars on ambulatory care in New York, we did not.
Well, talking about ambulatory care, and we're running down to the end of our program, I must get in about the stroke program you're very proud of that's been recently embarked here.
Yes. Well, the stroke program was built upon the trauma program, which we are a level 1 trauma center. We're one of the busiest in the state. And we had that infrastructure, so we invested in it. And when I got here 12 years ago, there were no official stroke programs in Brooklyn. It's
incredible.
It's the second-class citizens that we allow ourselves to be in Brooklyn, and we can't do that. So we recruited a stroke neurologist who I had worked with both at Mount Sinai and at St. Luke's Roosevelt. He came and he set up a team. So we have a stroke program now that is absolutely continuous. So we have it set up so that the ambulances contact the emergency room. By the time they get there, the stroke team is called. There's a CAT scan in the emergency room. We give more TPA, which is clot-busting drugs, than anyone else. We also have intervention. We've spent the dollars, the fragile dollars that we've gotten from the city council. We've been able to invest those dollars in interventional radiology. So the most up-to-date things that you see anywhere in the country in terms of intervention of removing clots, it's like magic. We can do at Lutheran, because that's what Brooklyn deserves, first-class care.
On that note, though, I want to bring you to a close, because I think that you have made Brooklyn a better place because of your presence here and what you've done for Lutheran in giving us a viable, powerful, professional hospital to go to on many levels.
Well,
thank you so much. Thank you so much for being with us tonight. I am delighted to have been with Wendy Goldstein, the CEO, the head of this wonderful Lutheran hospital. I'm Victoria Schneps, signing off. Until next time, keep reading The Home Reporter and Brooklyn Spectator and Spectator News. Thank you.